Welcome to the Infectious Diseases Society of America 2025 Guidelines on the Management and Treatment of Complicated Urinary Tract Infections. This comprehensive framework, developed by the Infectious Diseases Society of America, guides antibiotic selection from empiric therapy to definitive de-escalation. Welcome to the Infectious Diseases Society of America 2025 Guideline Overview. This guideline covers three critical clinical decisions in managing complicated urinary tract infections. Initial empiric antibiotic selection, a four-step process for guiding choices, and definitive therapy selection based on culture results. For empiric antibiotic selection in complicated urinary tract infection, prioritize based on sepsis presence. With sepsis, use third, fourth generation cephalosporins, carbapenems, piperacillin tazobactam, or fluoroquinolones. Without sepsis, similar options apply, but carbapenems and novel agents are deferred. Oral options like trimethoprim sulfamethoxazole or amoxicillin clavulanate may suit select outpatients. For sepsis, with or without shock, prioritize third, fourth generation cephalosporins, carbapenems, piperacillin tazobactam, or fluoroquinolones. Alternatives include novel beta-lactam, beta-lactamase inhibitors, and older aminoglycosides. Without sepsis, use third, fourth generation cephalosporins, piperacillin tazobactam, or fluoroquinolones. Oral options include fluoroquinolones or trimethoprim sulfamethoxazole, with alternatives like amoxicillin clavulanate. The Infectious Diseases Society of America's four-step approach for optimizing empiric antibiotic therapy in complicated urinary tract infection begins with assessing severity of illness. This is followed by evaluating resistance risk, considering patient-specific factors, and consulting the antibiogram for septic patients. The antibiogram's role is uncertain, so prioritize the most relevant organism, typically Escherichia coli, if prior cultures are unavailable. Severity of illness is crucial in selecting empiric antibiotics for complicated urinary tract infection. Septic patients face high mortality, necessitating broad coverage. Septic shock requires sequential organ failure assessment score greater than or equal to 2, vasopressors, and lactate greater than 2 millimoles per liter, with greater than 40% mortality. Sepsis without shock has greater than 10% mortality. Non-septic patients have 5% or less mortality, favoring stewardship and narrower spectrum agents. Prior urine culture results significantly enhance empiric antibiotic selection. Concordance with past culture data boosts appropriate treatment likelihood by over 7-fold. Negative predictive values are high. Fluoroquinolones 95%, trimethoprim sulfamethoxazole 86%, carbapenems 98%. Positive predictive values are lower, with fluoroquinolones at 76%. Predictive accuracy declines, with increased resistance prevalence and time since last culture. A systematic review highlights prior fluoroquinolone exposure as a strong predictor of resistance in complicated urinary tract infection patients, with an adjusted odds ratio of 13.7. Recent exposure increases risk. Avoid fluoroquinolones if used in the past year. Healthcare exposure and prior trimethoprim sulfamethoxazole use are weaker predictors. No strong predictors for extended-spectrum beta-lactamase or third-generation cephalosporin resistance were found. Clinicians must consider individual patient factors when choosing empiric antibiotics. Document all antibiotic allergies, including cross-reactivity. Assess renal function for aminoglycosides and cefiderocol. Avoid aminoglycosides in hearing loss, and use caution with intravenous fosfomycin in heart failure. Be aware of fluoroquinolone interactions, and avoid previously failed antibiotics. For septic patients with complicated urinary tract infection, use a local, recent, and relevant antibiogram to guide empiric antibiotic choice. In septic shock, select antibiotics with under 90% susceptibility. For sepsis without shock, under 80% is sufficient. Ensure antibiograms meet Clinical and Laboratory Standards Institute standards. Local, recent, relevant, and stratify by location when possible. Default to Escherichia coli unless otherwise indicated. Evidence from over 15 randomized controlled trials highlights key antibiotic classes for complicated urinary tract infections. Third and fourth generation cephalosporins like ceftriaxone offer 87 to 91% clinical cure rates, but should be avoided with extended spectrum beta-lactamase or high local resistance. Piperacillin tazobactam provides broad coverage, but faces rising extended spectrum beta-lactamase challenges. Fluoroquinolones and carbapenems are effective, but require careful stewardship due to resistance risks. Novel agents like BLBLIs, cefiderocol, and aminoglycosides are reserved for resistant, complicated urinary tract infection cases due to high costs and stewardship concerns. BLBLIs target carbapenemases with a clinical cure of approximately 91.9%. Cefiderocol, a siderophore cephalosporin, shows approximately 88.5% cure, but requires renal dosing. Aminoglycosides, including plasmicin, offer alternatives, but pose nephrotoxicity risks. For outpatient complicated urinary tract infection management, oral empiric therapy is an option. Consider bioavailability, urinary excretion, and resistance patterns. Ciprofloxacin and levofloxacin offer high absorption and excretion. Trimethoprim sulfamethoxazole and cefpodoxime are alternatives. Beta-lactams like amoxicillin clavulinate show inferior outcomes. Avoid nitrofurantoin and oral fosfomycin due to inadequate systemic levels. Antibiotic stewardship is crucial in optimizing antibiotic use, focusing on selection, dosing, duration, and route to minimize collateral damage. Preserving last resort agents like novel beta-lactam, beta-lactamase inhibitors, and cefiderocol is vital. Broad-spectrum agents increase Clostridioides difficile infection risk, while narrower-spectrum choices mitigate microbiome damage. Cost equity is essential, with daily antibiotic costs varying significantly. Once urine culture results are available, transition to a targeted, narrower-spectrum antibiotic. This de-escalation is crucial for stewardship. Initially, broad-spectrum coverage is used for up to 72 hours. Upon pathogen identification, reassess therapy. Consider oral step-down if the patient improves and susceptibility supports it. In outpatient settings, weigh benefits against patient burden. The IDSA panel emphasized patient perspectives in guideline development. With low mortality risk, patients focus on clinical cure and minimizing adverse events. Mortality was under 1% in randomized controlled trials, but 5.8 to 34% in real-world studies. Inappropriate empiric therapy occurred in 27.5% of cases. Novel agents can cost up to $1,500 per day, compared to $1 to $50 for ceftriaxone or levofloxacin. Sepsis status guides empiric antibiotic choice in complicated urinary tract infection. Prior urine cultures and fluoroquinolone exposure predict resistance. Novel agents are reserved, not first line. De-escalate to culture-targeted therapy promptly. Pharmacist involvement is crucial for complex dosing. Research priorities include microbiologic cure relevance, single-dose aminoglycoside use, and urinary tract infection management in gender-diverse individuals. Apply local epidemiology and clinical judgment.